what we found was that the patients who had the failed EVAR did not regress anywhere near as much as the patients who had the primary FEVAR. Hello, I'm Marc Schermerhorn. I'm the Chief Vascular Surgery at the BI Deaconess Medical Center in Boston. And I'm talking about failed EVAR and fixing that with FEVAR and how that compares to a standard FEVAR. And what we found is that the results weren't quite as good. And that was because the failed EVARs had ongoing sac growth, much more so than the primary FEVAR patients. And there's multiple possible causes of that. I found some of my patients had undetected type 3B leaks, and so I now completely reline all of these grafts. I also used to just reline by extending down to the old bifurcation and putting two limbs up, and that's not quite good enough. It leaves shoulders that can still get some flow out there, so now I use a bifurcated graft routinely, and I think that's important. I think the other thing it could be is from type 2 endoleaks. So sometimes the type 2 endoleak will cause expansion so much and that moves its way up, and then you lose seal at the proximal end. And I think that that's a common cause that we don't deal with if we just fix the new type 1 endoleak proximally, but don't fix the type 2 endoleak that caused it, then there's going to be ongoing problems. And so what we found was that the patients who had the failed EVAR did not regress anywhere near as much as the patients who had the primary FEVAR. And they also had a lot more type 2 endoleaks. And they had more reinterventions. And there was, in some studies, a survival difference, but that's probably not real after adjustment because these patients tend to be older and sicker. So the things are to think about, what was the cause? Is it a 3B reline? Is it a 2? You may have to keep going after those branch leaks. For type 2s now, I will attempt a minimally invasive approach once or twice, but if I feel it's futile, then I'll go to a robotic lumbar ligation now, which is a new thing, and that's seeming to work quite well for us. We have about a dozen patients, and we've even got one or two with regression before 6 months. The other things I think are important, I think it's good to know that, there can be challenging situations like tortuosity, which we can deal with by, a through and through wire to help straighten things out. Or I think manual aortic straightening is something I'll do by just pushing on the side of the aorta while trying to advance the device. Also, I think if patients have had suprarenal stents, that's sometimes off-putting, but usually that's not a problem. It's when you start adding in multiple layers of suprarenal stents and a palma stent across the renals, it gets quite a bit more challenging, but it is still feasible. But you will have to alter the tector using high-pressure balloons, maybe high radial force stents, etc. Other challenging situations, you have to deal with the short main body. It's usually only about 4 centimeters, and so you have to factor that into your planning. The grafts with the polymer rings are very difficult to seal into, and that's why the complete relining with a bifurcated graft is crucial for those. If there's pre-existing stents, like in the renals, then I think it's important to really flare those with like an osteoflash balloon to get them flattened as much as possible to facilitate the maneuver. Let's see what else. Iliac disease we can fix with the shockwave usually. At this point, it's important to note that these grafts are larger typically than the EVAR grafts, and so even if an EVAR went through, the fenestrated graft may not. Now, some grafts are lower profile, and with the physician-modified grafts I'm using, I can keep it to the same profile. Anchors are not a problem. And then finally, I would say that, we're doing these procedures because these patients are frail, but many of them can tolerate a hybrid procedure. So I don't think we should think of it as a complete failure. If you do have to do a renal artery bypass or a retrograde stent, that's a very feasible option for these patients and can sometimes get you out of trouble.